and for this series of health webinars focused on providing you with relevant, real-time, science-backed updates on COVID-19. I'm Gail Hogan. I will be your moderator for this webinar. We understand you want information and need answers to help protect your business and your employees. That is the purpose of this webinar series, to give you the numbers, the data, the facts as we know them today to help inform decision-making moving forward. A few details before we get started. All attendees, with the exception of our speakers, are muted. This session is being recorded and will be available on our website. Throughout this webinar, you may submit questions for our experts through the Q&A feature at the bottom. We will try to answer as many questions as we can. And if we can't get to your question here, we will capture your questions and reply to you after the webinar. Or you may email your questions to covid19consulting@osumc.edu. Let me introduce our speakers, and I am pleased to have with us today Dr. Susan Kolatar. She is the Director of the Division of Infectious Disease and Professor of Internal Medicine. Dr. Kolatar is Principal Investigator for a new COVID-19 vaccination trial, which she will be talking about later in this webinar. Dr. Andy Thomas is Chief Clinical Officer and Senior Associate Vice President for Health Sciences at The Ohio State University Wexner Medical Center. Dr. Thomas has worked on the front lines of Wexner Medical Center's medical division, and he has worked on the front lines in response to the center's response and management of COVID-19, and serves as an expert on providing best practice on a safe return to the workplace. Dr. Peter Moeller is Chief Scientific Officer and Vice Dean for Research at The Ohio State University Wexner Medical Center and College of Medicine. Dr. Moeller is directing COVID-19-based research for the Wexner Medical Center with more than 100 different research projects focused on COVID-19 across the medical center and the health sciences colleges. And finally, Dr. Ian Gonzenhauser is Chief Quality and Patient Safety Officer and provides leadership and oversight of quality and patient safety across the multiple units of the Wexner Medical Center. Dr. Gonzenhauser has led the efforts to provide safe and high-quality care to patients amid COVID-19. I'm going to start with Dr. Thomas. And Dr. Thomas, please kick us off here by sharing the latest COVID-19 data and trends that you are seeing. Welcome.
Thanks, Gail. Thanks so much for being here with us again today. And thanks to all the attendees who are here today watching the presentation. I'm going to share my screen here. What I'm going to start with is just a little bit of a snapshot of how we're doing as a state, and then to narrow down a little bit to our region, and then also to talk a little bit about the university, since I know many of you, I'm sure, have friends or family that work or are going to school here at the university. So this is a snapshot of the state's public health advisory system. This is last Thursday's release. I did hear earlier today on a call, it sounds like tomorrow's release is going to be even a little bit better with only 4 counties in the red. Just to remind you, I think we've discussed this before, the color coding system is based on how many of the indicators here on the right are positive. Each county is graded on 7 different metrics with basically, depending on how many of those are positive, determines your color. So some of those are forward-looking metrics. So they're looking at what patients are presenting to for the emergency department or to their primary care doc. Some are related to the number of cases currently being diagnosed over the last 2 weeks and the trends in that. And then there are a couple of metrics related to hospitalization, as well as the amount of ICU beds that are filled in a county. As you can see there, Franklin County is in orange. We've been in orange for 2 weeks in a row, and fingers are crossed we will be orange again tomorrow. But that's a big improvement from when they first started putting the system out, and most of the metropolitan counties were red early on back in late July, early August, when the system was first released. Also, just to remind you, we discussed this, I think, a little last time, the state is separated into 8 different emergency management regions for hospitals. So here at Ohio State, we manage what's called Zone 2, which is regions 4, 7, and 8. As you can see, it goes northwest on 33 and kind of north on 23, a little north on 71, all the way south on 23, south on 33, and east on 70. So about it's a third the geographic area of the state. It's over 40 hospitals. And really, when you think about Mount Carmel, Ohio State, and Ohio Health, we serve as a resource for all of the hospitals in that multiple county region, over 40 hospitals. So this is called Zone 2. Zone 1 is from Toledo all the way over to Youngstown, kind of the Akron-Canton area, and Zone 3 is the Dayton and Cincinnati markets. So if you look at where we are in Zone 2, or regions 4, 7, and 8 combined, here you see in blue the total number of patients in the hospital, in red the number of patients in the ICU, and in green the number of patients on the ventilator. So this is that period back in April and May when we had a huge spike in patients. Here is where we were, though, in late July. We got upwards of 80% of our peak from back in April and May. But as you can see, over the last 2 to 3 weeks, we've been hovering down right around 200 patients in the hospital across a third of the state. So certainly much better than where we were back in the late spring, but certainly not anywhere close to zero. The patients are distributed a little bit differently this time around, with some of the rural and community hospitals having 3, 5, 10 patients, but still about 80 to 85% of the patients being in either Ohio State, Ohio Health, or Mount Carmel facilities here in Franklin County. This gives you a sense, if you take the prisoners for the state of Ohio out of the equation, those are folks that are admitted to Ohio State. If you look at this peak back in April and May, of the members of the community that were in the hospital outside the prisoners, there were about 290 patients. We actually got this July within 10 patients of having the same number as we were at our worst peak back in the spring. And once again, we're now down to about 170 to 190 patients from the community in the hospital at any given time. The last slide I'll show is from the dashboard that the university releases. For those of you who are paying attention to what's going on at the university, obviously we've worked quite hard over the past month as students have come back onto campus to make sure that we've implemented all of the appropriate safety procedures for our faculty, staff, and students that are necessary in the classroom as well as on campus. Obviously, dorms are difficult living environments in some cases, but what we're finding is a lot of the off-campus housing is actually even more complex for patients, for students, to avoid getting infections. But the good news is, and once again, this is all publicly available data, as you can see, our positivity rate back in the first few weeks on arrival of students was in the 0.5 to 1.5% range, and then really got up to a peak of over 6% on August 31st, but it's come down very nicely since then. On 9/11, we had a bit of a bump, but if you look at actually the trajectory over time, we've now gotten down with the data release that will come out tonight with data through Monday, down in under 2% range for our total census testing. So we're testing all undergrad students on campus and a selection of off-campus students. And for on-campus, we're down around 1% positives from Monday's testing. So that'll be released this evening. But really a great, we had a good plan, but really it's been the students who've responded, who have really shown a vigilance around doing what they need to do to keep themselves and their peers healthy. And our hope is we're going in the right direction, and we'll continue that way, and we'll be able to keep moving forward as the semester continues. So with that, I'll be happy to take some questions at the end, but Gail, I think I will throw it back to you.
Thomas, I just want to remind everyone, if you are looking for the closed captioning link, go to the chat at the bottom of the Zoom page and you will find a link, and that will direct you to closed captioning. Next to Dr. Gonsenhauser. Dr. Gonsenhauser, could you share with us progress we're making in clinical recovery and patient safety?
There we go. Thank you, Gail, so much. Absolutely happy to speak to that. We've been obviously at the epicenter of the pandemic since it's first made landfall here in the US, and even before that, as we were starting to put planning together for how to manage the risk once we knew this arrived right here at home. We have, as you're all aware, a very large workforce. We have a workforce that is really on the front lines and is exposed to about the highest levels of risk that you can imagine when it comes to this pandemic and the risk that it poses to our workforce. We have staff, obviously, that are on the front lines treating COVID patients day in, day out. Thankfully, fewer now than in past months, as you saw on Dr. Thomas's slides. As we've approached this, we've really been very, very focused on our workforce safety and the safety that we protect in bringing people into an organization like this. What we've come to realize is that so frequently, even in an organization like ours, the real risk of COVID spread and the real risk of spread even amongst our workforce has been realized more so in the community risks than in the risks right here in our organization. In healthcare, for so long, we've learned to live with on a day-to-day basis these risks of viral and other pathogens and the risk that they pose to the workforce. So we've focused on PPE utilization and distancing measures and all of the things that we've been talking about for months. When it comes to how we've approached protecting the workforce and the environment of care here from threats from without the organization as opposed to our patients themselves, we've really focused on many of the same things that many of you in your businesses have probably started to put in place as people have returned to the workplace. Screening visitors and screening employees using temperature checking, moving from a manual front door temperature checking system now to a system where we really ask our employees to take that responsibility on themselves and just endorse the fact that they've checked their own temperature and are entering the environment without a fever. Obviously putting masks and personal protective equipment on everybody who comes through the door. And in the workplace, maintaining those social distances, safe social distances, as we focused on for months now in the community. Looking at things like the non-work components of work, things like break rooms and lunch times and the breaks that happen throughout the day. Those are the environments and those are the circumstances where people tend to put their guard down a bit and don't necessarily take the same precautions that they do when they know that they're walking into a room of a patient who could be a risk. This has been something that I think has been a cultural approach and a cultural change. It's been a challenge, but one that we've been able to engage our staff around and really bring them to the point of keeping these very specific precautions to avoid those moments of potential risk and spread in those non-clinical environments. Many of the same things that you'll likely be doing or have already done in your places of work. No sharing of food and limiting the number of people in a confined break area and things of that nature. So the front side precautions, I think most are familiar with, and they've been highly successful in our environment. In addition to that, the other real challenge is bringing people back to work after they've had either a potential or confirmed exposure. These recommendations have changed over time, and it's difficult to necessarily stay current on all of those recommendations. I'd say perhaps one of the most important things and one of the questions that we've heard frequently is the question of retesting after somebody has tested positive in order to clear them to come back to work. That is really something that is not recommended and something that we are not doing. Inside of the time frame of about 90 days following a positive test, we still don't know how short that time period can be before somebody would test negative with a PCR test. PCR testing, as you know, is highly sensitive. And so that idea of retesting within 90 days is something that we'd encourage people to avoid. It's not a CDC recommendation, and it's not a recommendation that we're utilizing for our workforce. We're really sticking to the CDC guidance as far as how to manage employees who have either had symptoms or tested positive. And they're much less restrictive than you may think. If you haven't been brought up to speed on these particular guidelines, they're available through the CDC website. And I'd highly recommend everybody becoming knowledgeable about them. Really, the CDC recommendations are for a period of 10 days since first symptom onset, or a period of 10 days since the positive test occurred, 24 hours with no fever, and all other symptoms improving. So those are really, the things that you're looking for, the milestones after somebody has either been symptomatic or come down with a positive test. And that's what you really want to require prior to bringing people back into the workplace environment. This is something, again, that's much less restrictive than people initially thought. I think it's allowing people to get a greater number of their staff and workforce back into the workplace. And these are the types of recommendations that it's really important that you stay current with, or you may be finding that you're dealing with older recommendations and it's really prohibiting you from bringing your workforce efficiently back to where you need them. So many things that we've learned along the way. I think probably most interesting and most pressing right now is the push for vaccination. And so Gail, I'm gonna toss it back to you so that we can hear from Dr. Kolatar.
Very much, Dr. Godzenhauser. You may have heard in the news that Ohio State University Wexner Medical Center will be a test site for a multi-center 30,000 person clinical trial testing an experimental COVID-19 vaccine in people. And a lot has been going on with this trial, so we are pleased to have with us Dr. Kolatar to give us an update on this particular study, as well as other studies Ohio State is working on. Dr. Kolatar, can you fill us in on what you're doing now and moving forward?
So thanks, Gail. Thanks everyone for joining today. I'm going to step back a second because I guess maybe this is like a tease or something, because I know everyone wants to hear about the vaccine, but I want to talk about sort of COVID in general and play off a few things that both Andy and Ian said. We really are all in this together, and control of this pandemic really requires all of us to do our part. I think we've seen some of that on campus with the students. We've seen it in the workforce with masking and social distancing. All that being said, none of that is easy to do. We are social beings, and the fatigue of doing this is real. So again, I'd just like to have everyone take a big deep breath and hang in there with us, because hopefully help is on the way. And when I say that, I say that in terms of not just vaccine trials and prevention trials, but other treatments as well. And it's been really the privilege of my career here at the university to be involved in clinical trials for all kinds of infectious diseases. A different virus, HIV, is what I've spent most of my time on. But again, I'd like to take a moment and just thank anybody who's ever been in a clinical trial. And so if you know anybody who's been in a clinical trial, and it doesn't have to be an infectious disease trial, it could be anything. It could be a cancer trial, a heart disease trial, whatever. Those are the people who are the real heroes in medicine, because they've helped us learn things and make a difference. So that's my little soapbox because I had it. So thank you all for listening to that. I think the important thing about clinical trials in general, though, is that they are designed to answer a question that we don't know the answer to. So with COVID, that is a lot of different questions, and they're designed to make sure that they're safe. So risk-benefit ratios are always important. And once you design a trial, there are clear mechanisms in place to monitor safety in a real time. And so let me jump into what happened with the Astrazeneca trial. First of all, the Astrazeneca trial was also is using a vaccine also referred to in the news as the Oxford vaccine. We saw that earlier on, probably several months ago, and with that promise, there came some excitement about a vaccine trial, and I'm going to talk about that whole concept in particular. But just to let you know, there was an adverse event that was noted by an investigator about 10 days ago or so. They informed the company, the sponsor, AstraZeneca, who did absolutely the right thing. They took the time to put the trial on pause, to really collect the information to assure that this unexpected event was not something that we were going to start seeing more of, that it was going to cause problems for the trial across the globe, that it was going to put people who participated in the trial at risk. And so I want to assure everyone that that was absolutely the correct thing to do. And I can tell you, doing other trials in the course of my career, it's not an uncommon thing to happen. We do trials because we're trying to find an answer to a question again, and we do them to make sure that people are safe. And if we find something unusual, it is actually a pretty common phenomenon. not quite as high profile as a vaccine for COVID, obviously, but a common phenomenon. So let me maybe I'm gonna try to not be technologically challenged and share my screen here. I hope. Am I sharing? It should say what could a SARS-CoV vaccine do? Everyone is muted, so I guess I don't. I'm gonna keep.
Yes,
I'm gonna keep talking. Okay. So vaccines in general really are typically meant to benefit the individual, both in terms, ideally in preventing infection, but even sometimes just in reducing the severity of illness. And now's a good time for me to give a plug for flu shots. That's one of the big benefits of flu shots, ideally preventing infections, but even if you're at risk for severe disease, reducing the severity of illness. So now's a good time for you all to start thinking about flu shots. And then in infectious diseases like COVID or measles or hepatitis or other things, benefiting the community is also the big benefit of vaccines. So again, reducing transmission and ultimately involving a healthier community. So there's lots of benefits to vaccines, and obviously the world will be better off if we can find something to be a preventive measure in addition to all the other things that we're doing. And so this is a super simple slide about just the principle of vaccine. So there's an organism, in this case SARS-CoV-2, these little spikes are important, that infects the body. The body, this is dramatic, sounds the alarm, but basically makes antibodies to stop this virus from getting into cells. This is a little more scientific picture, but let me just walk you through this. So this is the virus. This is the spike protein. People talk about this a lot. This is a human cell, and this is the receptor that the virus attaches to. So you can see the spike attaches to the cell, and then the virus gets into the cell and makes more of itself, and that's how it causes disease. Let me just digress for a minute and say the other thing that has been so, I think, disturbing to all of us about COVID-19 is the whole spectrum of disease that it causes. Some people have no symptoms, so they may think they may not have to take the same precautions. Some people have severe life-threatening symptoms and disease and end up in the hospital on a ventilator. And sadly, some people have died from this as well. So the whole range of disease makes it really, again, sort of a high anxiety type of approach. So this is the coronavirus, the spike attaching, and then the goal of antibodies, in a different color here, is to attach to these areas of the spike protein. So now these areas that need to connect to the cell, to the receptors, can't get there. And that's sort of the basic principle of vaccines, developing antibodies. This is a question I've gotten a lot recently. Can vaccines cause SARS-CoV-2 infection or cause COVID illness? They're as a rule, vaccines are meant not to cause infection or illness. In this case, absolutely not, because it's just pieces and parts of the virus that we're looking at, really looking at the spike protein. So much like a bicycle, you can't, if you have just a wheel and the handlebar and a chain, you actually don't get a bicycle. If you just have pieces of a virus, and in this case, the spike, but they're not all related in an integrated fashion, you can't get COVID-19. I'll go back to the flu shot. You can't get the influenza from the flu shot, despite what my grandmother would have you believe. So, personal thing there. And let's talk about how we test these things. So, and this is sort of a common phenomenon across the board with any intervention type of study. Someone has an idea about how to address the question of how do you prevent this disease. It's studied in labs, in cells, in animals, and then finally given to humans. And so the human trials go over courses of years, typically. Okay, so phase 1 are usually trials for safety, small numbers of people, make sure nothing really bad happens. Phase 2 can be a little longer, where you're looking for the best dose, how effective it is, usually more people. And then phase 3 studies tend to be even longer, with large numbers of people, and really trying to get to the question of, does it work for the majority of people, and is it safe? The different thing about the SARS-CoV-2 vaccines is that it's going at rapid speed. The government operation is called Operation Warp Speed. So as the name implies, everyone's working very quickly. So phase 1 happens first, and often is combined with phase 2. So when we talk about the Astrazeneca vaccine trial in particular, phase 1 happened and then went right into phase 2 in more like in more like 6 months as opposed to 18 months. And so that's where we are. And so the early stages of the trial didn't really show anything. The phase 3 trial that which just started did show a neurologic event, a condition called myelitis that's being investigated. The FDA here in the United States is looking closely at the data so far, and we expect that hopefully soon it will be opened again. The vaccine study, a little bit different design, but using the same vaccine, being done in the UK and Brazil, opened up over the weekend. So I think that's what everyone really, really wanted to hear. This is a trial that's looking at this vaccine that's genetically engineered. They basically use a I love this little graphic here, like making a sandwich. You need something to carry the spike. Oops, I'm sorry. I'm having a little. You need something to carry the spike protein part of it into the cells, and so that's called the vector. And then the filling is the antigen, or is the insert is the antigen. So it was done with using a chimpanzee version of an adenovirus vector. Adenovirus vectors are basically viruses that cause the common cold. Many of us have been had adenovirus infections, much like not getting COVID from the vaccine. You also cannot get adenovirus because they've made it so the adenovirus can't replicate either. But what they do is they make the virus, the adenovirus vector, engineered so it actually makes the spike protein, and that's how it works in people. So you give the vaccine, give the body some time to make some antibodies. This vaccine requires 2 shots. So and it's really people who are at risk. Certainly, we would like people who are most at risk of serious illness from COVID to be enrolled in the trial. That includes people both based on age and based on what kind of exposures they might have in the work environment, or which racial and ethnic groups who may have some risks are involved as well. So that's our big goal here. I think I'll quit sharing my screen now. So I've started out saying this. These are the reasons we're doing it. We want to find something that is safe and something that will either reduce the severity or ideally prevent COVID. And so we're very excited about this. I think we have lots of opportunities to truly make a difference. I think this is great for the Central Ohio community, and I've been very appreciative of all the support, and certainly Dr. Moeller can speak to this too, that's been given to really get this trial running. So I am hopeful that we can get things moving. Obviously, we won't do that until we're given the green light, but we'll go from there. I think I might have another minute or two. I would like to talk about, without showing you a lot of scientific slides, I would like to talk about other trials that are going on, because I think what's important for us to, again, appreciate is that since this is a new virus, we really started off with not having many things to do. And a lot of things were touted in the press to maybe be potential treatments. Most of them have not panned out to be correct. But there's also a whole new wave of looking at specific treatment trials, specifically for COVID. Some of them take advantage of this antibody concept, and they're called monoclonal antibodies. So someone who's been infected with COVID and has some symptoms, but mild symptoms that may not necessarily require hospitalization, there's a way to give antibodies, like sort of as almost as a passive immunization as a treatment thing. We also have some other studies going on in the hospital with some pills, which of course would also be a useful tool along the way. Maybe I'll stop talking because I feel like I've been talking a lot, and either send it back to you, Gail, or happy to answer any questions that people might have.
Dr. Kolatar, I have two quick questions before we move on to Dr. Moeller, and one would be a timeline for the vaccine. And we have heard the timeline, and you're involved in it, so maybe you can give us a better guesstimate of when we might be able to see this vaccine come to fruition.
You mean after the trial is opened up again?
Yes.
Yeah. Okay. Well, so it's a again, as we've so almost merged at the times of phase 1, 2, and 3 trials. One of the ways to try to get a quicker response is by enrolling large numbers of people. The trial actually nationwide is hoping to enroll 30,000 people to see if it makes a difference. And I guess I probably should have said this is because we're looking to see how effective it is. It is a placebo-controlled trial. So 2 out of 3 people will get active vaccine, and 1 of those 3 will get a placebo shot. We won't know. It's a double-blind study. The investigators, I won't know. My research team won't know. The patients won't know which arm they've been randomized to. And then we are following these people over time for 2 years. I think if this were normal times, which it clearly is not, I would say we should wait the full 2 years. I believe all the vaccine manufacturers have agreed not to do quick releases or emergency use releases based on limited data. I think I'm not answering your question because I don't know the answer, but if the answer is it going to be November? I don't think so.
Thank you very much. And that does lead me to my second question, which is, you said 30,000 people nationwide will be in this clinical trial. How many here in Central Ohio and Ohio State?
We are targeting 500.
Okay.
So
Dr. Moeller, thank you for your expertise. We appreciate the update. And I'm going to check in with Dr. Moeller to see if he has anything to add. Dr. Moeller?
Sure. So I think the only thing that I would add to what Dr. Kolatar said is that each of these vaccines is going to be a little bit different. Now, they all target the virus, but they all do it in a little bit different way. And so I think that it's important to know that we may see over the course of the next few weeks or the next few months that we might see some of the things that happened with the Astrazeneca trial, where there might be patients that have issues or unexpected results. And so I think to Sue's point earlier that it's not unexpected, and the public should really understand that we're going to likely continue to see this going forward. It's pretty common, and it's important that before millions of people are injected with a vaccine that it is truly safe. I think that's important. I think, Gail, the only other thing I was going to comment on today was a little bit, we've heard a lot about playing offense today, and we've heard a lot about playing defense, which is appropriate on a Big Ten football big announcement day. I do want to update a little bit on testing, because I think it's something that is part of both. So we need it for both vaccine development, but we also need it for safety. And Ohio State got into the testing game very early with Battelle, as you all know. And right now, I think Andy can correct me, but I think we're around 200,000 tests that Ohio State Wexner Medical Center has done. And this is beyond the testing that is happening for the students in the university side. For the people that are on the call, it's important to know that there's multiple types of testing, and they're going to start hearing a lot more about a type of testing called antigen testing. And so the gold standard that we've talked about for the last few months is the PCR test, which looks at the DNA or the RNA of the virus. They're going to start hearing again more about this antigen test, which looks at the protein. And so looks a little bit more at the active form of the virus, but is a little bit less sensitive. So again, instead of looking at the DNA, this sticks to the surface of the virus or the spike protein, like Dr. Kolatar just mentioned, and it's going to allow us a little bit of a better way to have a mobile view of what's happening with the virus, to be able to look a little bit more in the field in a way that's a little bit more economical. And so you'll probably see this more adopted. It's the test that we're going to see the football team using or the Big Ten using to test a lot of the athletes. But it's probably not as accurate as we're going to see with the PCR test. So the people that are most susceptible to having outcomes with the disease, so people that might be over 70 or people that have had an underlying condition, will likely continue to be tested with the PCR test. So we can happy to answer any questions about that later. Lots of questions about things like false negatives and false positives. But as the scientific field continues to refine the testing modalities, we'll continue to make these even more accurate.
Dr. Moeller. And Dr. Kolatar, I'm going to go back to you for one moment. I know you have something that you wanted to add, but I also have another question regarding the vaccine and when it is available. And when it is available, is there a way now to roll it out? Do we expect healthcare workers to get it first, or people in that strategic population that are more susceptible to being very ill? Any ideas?
Well, I guess I would hope that the people who are at most at risk would have first access. I mean, again, these are huge collaborative undertakings in terms of not just vaccine manufacturing, but delivery and output. So again, I don't have any crystal balls, but I think certainly frontline workers would be high priority, and other really at-risk populations. I think we need to continue to pay attention to that.
Yes, Sue, I can chime in a little bit there, Gail. There's actually a working group that the federal government's put together related to this that are working with the state health departments. The Ohio Hospital Association and our zone leads for the 3 zones are working with ODH on trying to figure out how do we take that general guidance that the federal government's going to provide and really operationalize that to distribute the vaccine across the state. We do know that on day one that there's vaccine available. It's not like they're going to drop 11.7 million doses of it on the governor's desk. You know, we might get it in batches of 100,000, 200,000, whatever it might be. So the ability to prioritize patient populations, the ability to prioritize frontline healthcare workers. So potentially not everyone who works in a healthcare organization, if you work in finance or marketing, as valuable as you are to the organization, you, much like Ian or I, are probably not going to be first on the list to get vaccinated. It's going to be a nurse or a doctor working in the emergency department, working in the ICU. So we're going to have to prioritize populations, both within the healthcare system, as well as folks that work in nursing homes, first responders, and then also looking at patients who are actively being treated for cancer, have organ transplants, potentially have diabetes or other things that would impact their ability for their immune system to work well to fight off the virus. So especially given that they're most likely, most of these vaccines are going to take 2 shots, it's going to be a while until, for example, every K through 12 student is vaccinated. It's just not going to be, maybe this time next year where there's going to be enough vaccine where you're going to see broad swaths of the low risk population in the United States being vaccinated. There's all sorts of other things we could talk about if you'd like. For example, right now, some of the vaccines need stored at -70 degrees Fahrenheit. And there's literally a run on the freezer market in the country now because we have to find a way to store tens of thousands, hundreds of thousands of doses of this once it gets to us. So we're working through all those things literally on a daily basis. I've been on call since 6:30 this morning, both internal at the medical center, internal at the university, and with folks at the state, just working through all of these issues. So.
Yeah, and then thanks, Andy. And I guess I would add to that, we also hope to learn from trials if there are any groups that get a better response rate or not as good of a response rate. I mean, it's certainly feasible that if you're in your 80s, you may not get any response. I mean, that's not what we hope, but I think, again, taking all the information that we learned from the trials will be important. The other thing that I neglected to mention, because I got sort of distracted talking about the current trial that we're doing, is that there are at least 9 other manufacturers who are looking at trials where we likely will do, again, as Dr. Moeller suggested, they work a little bit differently. They conceptually are the same, but in terms of formulations and how they express the spike protein are a little different. So there's, it's without sounding too goofy, it's an exciting time to be in medicine. We're just learning things at such a rapid speed.
I do have an interesting question from one of the folks, and this is for all of you, because this person said you are all medical professionals, medical experts. What are you doing in your personal life to make sure that you don't spread this virus?
Ian, you want to cover that?
Yeah, sure. That's a great question. You know, it's funny that question is asked, because just yesterday was the first day that we returned to, my wife and I, using a gym, and it's something that we've avoided for the duration of the pandemic, and we were very, very skeptical about returning. And it was only after really weighing the precautions that were being taken and talking to people who had experienced it, to really understand, you know, is distancing working? Are people adhering to the protocols and precautions? Do we feel that the precautions are ultimately the right things and the things that are going to keep us safe? And ultimately, we made the decision to return. And somebody commented to us, you know, they said, it means a lot to see you back here, because you're really kind of what we're using to gauge what's safe and what's not. You know, we have 2 children in school-age kids, a 4.5-year-old and a 7-year-old. The 7-year-old is just starting hybrid schools again. The 4.5-year-old is in full-time, in-person preschool. You know, we're doing a lot of the same things that I think everybody is doing. We're still restricting our social circles. We're still making sure that if we are going to pursue a social engagement, it's an engagement that truly is distanced and with masks and responsible. You know, we've been not traveling. If we're traveling, we've traveled by car, and, you know, we're going places where we know the environment is controlled. We're wearing masks everywhere we go. We recently had the 4.5-year-old develop some sniffles after her first 2 days back at school, which was terrifying for all of us. And we put her in a mask, and she wore that mask, you know, until we were pretty sure that her symptoms were clearly, you know, on the decline, and this wasn't something that we were concerned about. When we visited my mother a few days during that period, we all wore masks, because we didn't know, and we weren't sure of our potential risk to her. And she's obviously in a higher risk category. So, you know, I think we've been doing all of just the basic precautions. We are cautious, but we're not hysterical. We're cautious and caring, but we're not overly dramatic. You know, we're not burning our clothes before we come into the house. We're not getting into the hysterics of this could be on every surface and everything is a threat, but we're taking just cautious and thoughtful and purposeful actions to adhere to the things that we have identified work. And it's been effective for us. And it's not easy, as Dr. Kolatar said. And there's a lot of new information coming out all the time still. And so adhering to those things, paying attention to those guidelines, paying attention to what's new and what we're learning, and just taking a cautious approach. That's how we've approached it. And it's been, for the most part, pretty comfortable. I will say, returning to the gym, I was really uncomfortable. And I'm still not quite sure about that one.
Yeah, Gail, along those lines, I think what we found here at the university, as well as at the medical center, and I'm sure the same will be true of the employers that are, you know, watching today, you can put all of the right policies in place, barriers in place, spread out workstations, all those things. The risk of someone at the office spreading this to others at the office is really about compliance with those policies, but it's even more so about what they do in their free time. Right? If they're going to large parties in people's backyards where there's no masks, if they're going to bars and large groups of people, Peter's already referenced football. They've announced we're not going to have fans at football games, but if you're going to your kids' games and you're mingling with people without a mask on, those are the risks that are going to be more likely to bring that into your office. And no matter how good your protections are in your office, your risk is going to be higher if your employees are doing risky behaviors outside the office. I think it's the same is true for the schools our kids go to. The schools can have all the best policies and procedures in place, but if those kids are taken to parties or they're being exposed to risk, it breaks down. It's that Swiss cheese of multiple barriers. That's what Ian was talking about: wearing a mask, social distancing, washing your hands, and washing high-touch surfaces. All four of those things need to go together. But if you're only doing that 50% of the time when you're at work and not doing any of it at home, that's not gonna, get the job done.
Next question. Current CDC guidelines said isolation for positive COVID-19 patients is 10 days after symptoms. How likely is someone after 10 days of isolation still contagious?
Sue, do you want to cover that?
Yeah, I think really, really, really low. They've not been able to find much virus after 10 days. Enough for the CDC, who is generally a conservative group, to say 10 days is enough. I think maybe Andy or Ian, you can correct me. I think the last thing I read was much past 8 days is really, right. People are not finding much viable virus.
Right.
So
when they're actually testing for virus that's growable, in other words, not just the presence of virus, but virus that can replicate, they're not finding that after 7 to 8 days in most patients, which I think is where the 10 days comes from. But remember, it's not just 10 days. It's also 10 days, no fever, and symptoms improving. Because if you actually end up in the hospital, it's 20 days, right? So if you're getting worse at 10 days, it's not 10 days, right? It has to be 10 days with 24 hours fever-free with no medications that'll reduce fever, and also with symptoms that are improving, which would mean your cough is better, your body aches are better, all those things. If you're still having symptoms at 10 days, it's not 10 days.
Yeah, just one comment that I would add to that. I think the importance of that time period after symptoms are abating, certainly something that you want to pay attention to. Something that's really important for people to keep in mind is to not be seduced by the negative test. And that, having a negative test immediately after an exposure, or, immediately after maybe you're concerned about a risk, that is not something that means you can avoid quarantine, avoid distancing, avoid all of those measures. It's very, very important after a potential or known exposure to really maintain that time period to monitor for symptoms, despite what a test may tell you immediately after. The test isn't necessarily, totally telling or necessarily very valuable at all if it's the day or 2 days or 3 days after a potential exposure. So be very, very cautious if you're using testing following exposure to still maintain those standards of the time period required to monitor symptoms.
Yeah, and let me reemphasize that's 14 days. That the likelihood of the time to develop symptoms is somewhere as soon as 2 and up to 14 days. Most commonly around a week, but there's a pretty big range there. And so having a negative test isn't a get out of jail free card.
Dr. Muller, I'm going to address this next question to you because you have already talked about antigens. And so the question is, what is the average turnaround time for antigen tests? PCR test is about 2 to 3 days.
Right. So some of the benefits of the antigen test is that it's very rapid. It's not as high throughput, and remember, it's not as accurate as the PCR test, but usually they're between about 5 and 15 minutes. So that's a big advantage. One issue though is that it's hard to scale them. So you can't run 1,000 of them at a time. You can run, sort of between 1 and 8 at a time. And so again, I think one thing just to comment on quickly is everybody keeps talking about which is the good test and which is the bad test. And I think hopefully one thing that we can just sort of convince everybody today is there's not a good test and a bad test. There's the right test for the specific indication. So who might be the sickest? What do you need to have done fast? What is your role of accuracy? So it's they're both important, and we need to continue to develop both of them.
Thank you, Dr. Muller. And thank you all for all this information and being able to not only access the latest data for these folks, but also have experts like you interpret it So I want to now ask Dr. Gonsenhauer in the few minutes that we have left to share information about new services from OSU to help employers. Dr. Gonsenhauer?
Yeah, thank you, Gail. I think if one thing is abundantly clear through this conversation, it's that there's a lot of information and a lot of new information just about every day about all of these various components that we're putting together to understand how to manage this pandemic. If it's about testing or treatment options or isolation and quarantine, you know, there's so many questions about how to effectively manage the various risk points of all of this. As an organization, again, really at the epicenter of what's happened over the past 6 months here at home, we've, I think, really worked through addressing as diligently as possible as many of these risk points as we can. And we truly do have experts who are living and breathing this every single day. It was not hyperbole when Dr. Thomas said he's been on the phone since 6:30 in the morning working through these things. That is absolutely accurate, and it's most days. And I think the same goes for Dr. Moeller and Kolatar and myself. So, you know, we really are committed to being a resource for Central Ohio. As much as we love taking care of the patients of Central Ohio, we'd prefer to provide preventative services that we don't have to take care of them in the hospital. That is definitely our mission. Our mission is to better the health and wellness of all of the members of this community. And so the experts that we have available who can help move through these questions and answer and put together planning and strategy for businesses and other entities in our community, we really want to be able to provide that. And we've put together a process and a program to do just that. We have a variety of different kind of levels of offering, if you will. We are here to provide some of the resource and training that we've determined is necessary for us to work through this efficiently and effectively, to provide that to somebody in one of your organizations who can be a local expert for you, who can then just use us as a lifeline when they have unique or specific circumstances that they need help with. So if it's training somebody in an HR department to really be your source of truth and strategy for managing this, that's something that we are very prepared to do and would like to do. If it's providing consultative services for, you know, a one-time phone call to help you work through a challenging issue or interpret a guideline or result, that's something else that we're prepared to do as well. So we have a variety of sort of service offerings to support the entities in the community, the businesses and nonprofits, and we're here to do so and really want to do that. I think an evidence of that is just the information on this webinar. Dr. Thomas was kind enough in the chat function to put a link to that CDC guideline that we discussed about not testing within 90 days. It's just our ability to process this information and distill to you, what's really relevant and pertinent for your business operations. That's something that we'd like to provide because we know there are a lot of questions. We know that there's a lot of misinformation, and we want to make sure that you really have the best and most current information to make those decisions and manage the safety of your workforce. Again, we do this out of commitment to the people of Central Ohio and beyond. And this really is about health and wellness. We are here to support that, and it's part of our mission.
Thanks, Dr. Gonsenhauer. And I want to remind folks, if they would like more information, to go to this website. It's COVID-19 Consulting at osumc.edu. I would like to thank all our experts. Thank you so much for your expertise and for your time this afternoon. And we thank you all for joining us. We hope you will join us for future webinars in this series for the very latest on protecting your business and employees during COVID-19. And once again, that email, if you want more information, is COVID-19 Consulting at osumc.edu. Thank you all. Be safe, be well.
Thanks.
Thanks, Gail.
Thanks, Gail.